afternoon, everybody. That's it. Good afternoon, everybody. I want to hear from you. So I've been given the session after lunch. I know you were expecting the drummers to sort of get you back and that energy returning after what has been a fantastic start to the conference this morning. Let me begin by saying huge thanks to Khan and colleagues for inviting me to do this talk today. This conference is so special. I remember the first time we spoke, and the second, about the importance of us coming together to have the space, the time, the energy, and the passion to focus on what matters to us as Black people, and to have those tough conversations about why we are not progressing as fast as we should, and why the health inequalities that affect us seem so unmovable. But over time, we have not only spoken about these differences, but we've also acted. And this morning's start to the conference, you've seen such dynamism in terms of the evidence and the practice and the innovation that's coming from our community. So as we participate today, and as you participate today, I want you to listen, to learn, to engage, to ask, what more can I do? Who should I be partnering with? And how do we ensure that we're working to get better outcomes for our communities? So in the presentation today, I've been asked to focus on a few things, and perhaps what I'll do is to, let's see if I'm going backwards or right. What I want to do today is to stand back a bit, to reflect on how significantly our health and care system is changing, and then to ask ourselves critically, how and where do we begin to ensure that as we have a new NHS, as we have local government changing, as we have the entire system changing, that resolute focus on tackling inequalities, on tackling structural discrimination, and embedding everything we've learned over the past 5 years remains part and parcel of the new health and care system that we have. So the time that I have available, I wanted to reflect on these few things. Most of all, though, I want to ensure that we keep central to our focus this question. And the question is, how do we secure a healthy future for everyone, leaving no one behind? It's a question that gets me up every morning. It's the question that underpins the values that I bring to my work as a public health director. And it's the question that holds me to account, right? So if I'm not seeing the improvements in health and well-being and reduction in inequalities in the populations that I serve, then I must ask myself, why not? And what more do I need to do? We are really living in an exciting and challenging time. I'm not going to speak about global events, what's happening in the Middle East. I'm not even going to be speaking about the cost of living crisis and the challenging times socially, structurally, politically that we may find ourselves in. But I am going to speak about the transformation of the health and care system and this once-in-a-generation opportunity we have to really step back and to think about what the government's trying to achieve with this new 10-year health plan, and the new direction and the new energy that it brings to us. Now, a number of the previous speakers this morning have reflected on the role of the 10-year health plan, its ambition, its comprehensiveness, the fact that we're thinking of these 3 shifts, where we're for once really putting prevention and digital and the community at the center of how we think about the NHS and how the NHS needs to change to meet the needs of a changing population and changing environment. And just to summarize the shifts, you have, and I'm sure this is familiar to all of you, you can see that whether it's moving from hospital to community, thinking about GP practices, community hubs, neighborhood health, what we need to do to think differently about mental health care are all part of what we need to be thinking about. The shift from analog to digital means that we have more digital tools available to us, whereby we're able to do things at scale, do things more quickly, target populations who are the greatest need, and use digital tools to engage them in their health journey. And most importantly, that shift from sickness to prevention means that we have an NHS that isn't just focused on treating disease, but is actually saying, how can we help you to do better on vaccinations, better on screening, to take control of your health and well-being. Now, you can look at all of these commitments in the 10-year health plan, and you can ask yourselves, what would happen if we achieved all of those ambitions, but we didn't do it in an equitable way? Who would we leave behind if we built our systems in neighborhood health, if we thought about digital but didn't think about digital equity and digital literacy, if we moved towards sickness and prevention and didn't think about the equitable dimensions of moving to prevention, all of these ambitions could result in us leaving people behind. And in fact, many of them would result in widening inequalities rather than narrowing inequalities. So we're at the beginning of the 10 years of the 10-year health plan. Now is the time to ensure that we're building equity into the 10-year health plan. And that equity looks like this and in different ways. It means that when we're thinking about the new operating model for the NHS, whether we're thinking about the new role of ICBs, the new role of regions, provider collaboratives, setting up new neighborhoods, we must be asking ourselves, how are we building equity, equality, and the considerations related to stigma, discrimination, exclusion into the design of new systems and the new operating model? It means when we're thinking about transparency of data and thinking about improving quality, we begin to ask ourselves, well, how does this relate to the quality that we see on maternity services or mental health? The things that you heard earlier this morning, which are driving inequalities within our community, we must ask ourselves, are we collecting the right data? Are we using the right tools? Are we thinking about equity at the forefront of the design of these services so that transparency of quality is benefiting everyone? And third, as we design the system and we think about new innovations over the next 10 years that will get us towards the end of the 10-year health plan, those big technology bets, the thinking about innovation zones across the country, the work on fast-tracking clinical trials, and of course the work that we need to do on the research and regulatory environment. Are we having those conversations on equity at that table? So we're not building in equity as an afterthought, but we're designing these systems to meet the needs of the most vulnerable populations. So the 10-year health plan and the key elements of it, I think, are incredibly exciting. But it does mean that we have a responsibility to ensure that we're building this new health and care system, and we're building it with equity at the center of what we're trying to do. So you will hear for colleagues working within the system, us talking about the new financial foundation for the NHS, this focus on quality of care and workforce which is fit for the future, innovation to drive reform, leading to this new operating model for the NHS. It's so important that you all understand how the system is changing and where each of us needs to play to ensure that we are continuing to advocate for the issues that are being discussed today. Now, I start with structure because in understanding the structure, it will help us to understand how we best think differently about the nature and scale of health inequalities that we're faced with, and therefore where we need to work with and target and change in the new health and care system to have that impact. Many of the health inequalities that we've been discussing and you've heard about today are long-standing, they are pervasive, they are unfair, and they are unavoidable, and they really talk about systemic differences in how people access, experience, and the outcomes they have from engaging with a service. Many of these disparities are not random, but as you know, they're rooted in the social and structural determinants of health. And that's exactly why we're here today, to really understand that interplay and therefore how we use and work with the new NHS and health and care system to address them. And of course, what we know is that these health inequalities are manifesting themselves in many, many different ways, whether it is differences in life expectancy, access to health care, or the burden of various conditions. So as we're thinking about these new systems, we have to be saying, how will it improve access, equality, experience, and outcomes, and help us to reduce inequalities? The data are absolutely clear. When you look at what's happening, especially in a post-pandemic, COVID pandemic period, we're seeing in many places a worsening of inequalities or widening of inequalities. Here the data is just showing that healthy life expectancy at birth has continued to fall for males and females in England and in the UK in the period leading up to the pandemic, and we've seen similar declines post the pandemic as well. And these declines in healthy life expectancy and life expectancy are seen across the country. This slide is showing regional differences, which have largely remained, with those people living in the northeast having some of the lowest healthy life expectancy since 2011-2013. Again, we are not improving, and in many areas, some of those inequalities are widening. But you could look at other forms of data that really say that even though we're changing the system, we have to be laser focused on tackling inequalities. Here we see that healthy life expectancy is lower for women in more deprived parts of the country. And in highlighting it, I'm going to be showing a series of maps of the country which show the variation in these outcomes, and why, as we redesign systems, it is so important that we build from the bottom up, from neighborhoods up, that understand the lived experiences of our communities, the realities of their lives, and how we shape the new health and care system to meet those needs. So whether it's healthy life expectancy and some of the differences that we see, but also the factors which drive those differences in healthy life expectancy, which include, are people smoking? Do they have poor diets? Are they using alcohol, drugs, or have low physical activity? Many of these behavioral drivers or individual level drivers are driving those differences that we're seeing across the country. But of course, we know that there are other factors driving the differences in healthy life expectancy. The jobs you have, access to air pollution, and of course, body weight and other metabolic factors as well. I share these differences because not only are we seeing them, in fact, influencing the key drivers of healthy life expectancy, but we can look across the country in other domains of inequalities. Here we see the proportion of people with diabetes, which certainly has increased as obesity has increased as well. And again, across the country, significant geographic variation. We could look at mental health. Over the past decade, increasing diagnoses and proportion of people with a diagnosis of depression, and again, significant variation happening across the city. And again, the slide, or the chart on the right of the slide, just shows the distribution of the prevalence of diabetes by a particular local authority. And you can see significant differences depending on where you reside in the city. Already this morning, we've reflected on maternal mortality rates and some of the differences that we're seeing, and the disproportionate impact that we see in poor maternal mortality rates, especially among the most deprived parts of the country, and significant differences we see for Black women as far as maternal mortality is concerned. Again, finally, we can also look at distribution of behaviors such as use and harmful use of alcohol and the rates of death related to alcohol. And again, the high concentration of those deaths according to level of deprivation and how that then manifests itself across the country in terms of changing geographic prevalence. And the final slide that I wanted to show in terms of differences really highlights air pollution. Now the evidence is saying that air pollution is having not only a significant physical health impact, but also an impact on mental health even increasing your risk of acquiring dementia. And again, you can see significant geographic variation, even though air pollution levels have been improving over time. I wanted to share the data because I wanted to root and ground this final part of the presentation into your understanding of why these inequalities occur, and why they're so important, and if we have system change, how we might work together differently to achieve that. So Michael Marmot, many of you will know, has always said that the reality of our health is dependent upon the state of the society and the distribution of power and resources within it. So as we're changing systems, we need to ask, where is the power? Where are the resources? And how do we ensure that we're at the table helping to articulate the strategy, the values, the principles, the metrics that should guide how that system is developed. So let's talk a little bit about health inequalities. I want to now use the model that's being developed to talk about how we may do things differently when it comes to addressing and tackling health inequalities. And I want you to focus on this because the strategic documents which underpin the change that we're going through at the moment are absolutely clear that we should be focusing on health inequalities. The 2024 Plan for Change, which set out government missions, speaks to the fact that people are living more of their lives in ill health, and the gap in healthy life expectancy is in fact increasing. And therefore it has called for action on this as part of what we do, calling for actions on the main drivers of ill health and persistent inequalities. And again, I've already highlighted the 10-year health plan, which is again providing that focus for us, saying that the health mission must be delivered. And again, the overall ambition is to reduce the gap in healthy life expectancy. So, if we're going to be doing this, let's see how we work with this new system then, and what should be different in order for us to think about how we tackle inequalities in the emerging landscape. The new health and care system in England will have different components. At the national level, you would have heard that the department is merging with the NHS England. That provides national leadership, do once for delivery functions. At the regional tier, which is where I work, I'm the Regional Director for Public Health for London, we're going to be involved with the regulation and oversight of NHS trusts and ICBs. We'll be doing more work on strategic leadership of the system, more work on holding systems to account, and looking at the data on financial management. Is your commissioning of services actually improving population health? And we'll be looking at delivering at-scale functions. And then, of course, you have, at the local level, providers, ICB trusts, and of course, neighborhoods, which will be where services are delivered, where services are commissioned, and where that sense of what problems are we trying to fix in communities, and how do we leverage the tools that we have to ensure we're commissioning better and we're commissioning differently. Now, using myself as a public health director for London, there are things that I will be keen to be doing in this new system. And I thought I'd share that with you today, because when you leave and you're thinking about, well, how do I get my work in front of the key decision makers and the people who may be able to help us to do things differently, I'm hoping this provides even one model for how we may work differently. In my work, we obviously are doing work to look at the local needs of populations and ensuring that we're agile, providing advice on how services should be commissioned. We're working collaboratively across many organizations, the NHS, local government, businesses, academia, to ensure we're bringing health to the table. We're making sure that evidence underpins the decisions that are being made when it comes to commissioning services in the future. And of course, supporting structural and social determinants of health and action on those determinants of health, especially through centering community-centered approaches. As public health directors and colleagues working at the regional tier, we're going to be involved in three key things. First, providing strategic leadership. Second, thinking of performance management. And third, how we improve and intervene in systems. Again, I'm sharing this because as the system is changing, understand where you're able to influence is incredibly important. So let's look at one of these. Let's look at systems leadership. So how, at the regional tier, might we bring people together to focus on what really matters in regions, what matters to ICBs, how neighbourhoods should be integrating some of the core principles on what they should be doing differently. At the regional tier for systems leadership, we should be doing things such as convening and aligning partners, really making sure that equity is embedded in everything that we do, driving priority programs within place, and thinking about funding, ensure funding is fairer, more fairly distributed, and building on the evidence for what works. And there's some great examples of this that's been done, whether in London, in the southwest and east of England, where this model of system leadership, bringing people together to focus on population health and leverage the systems that we have and the tools that we have to do things differently are in place. Assuring that what the system says it's going to do is actually done is a second key function that we have. And a key part of that assurance is again highlighted here. It's about building equity into that assurance process. Are we having the metrics that says, are you doing a better job or a worse job in reducing inequalities? And can we measure just how well you're doing it? We're thinking about how we look at joint assurance with local government because of the role of the public health grant and how we use the public health grant to commission better services that can improve health. We use data as part of the assurance process, new metrics, so that what gets funded gets measured, because what gets measured gets done. And it's really important that we use the new system to be thinking in that way. And finally, aligning with national priorities are a key aspect of what we do in the assurance function as well. Finally, the third element of our work at the regional tier, whether in public health or in clinical services, would be to drive improvement in systems. Thinking about how we think about digital inclusion, how we build in systems which are focused on looking at shared data platforms, where we begin to turn data into action, and where we think about best and promising models, and we work to share those practices across regions and across cities. This is incredibly important because we know there are pockets of best practice happening everywhere across the NHS. But the failure that we have is the failure to translate, the failure to share, the failure to scale, and the failure to really gain the benefits from population health from those efforts. So, I'm now going to close. I really want to begin by reflecting a little bit on where we are with the transformation of the health and care system in England, why the focus on equity remains incredibly important, and to talk about specifically an example of how the regional tier of the new system may be able to help. But at the end of the day, what I hope is that wherever you are working in this new system, the core principles of what works to tackle inequalities will remain true, and we will hold ourselves to these. And what are they? They are that we have a well-resourced, well-focused, equity-focused public health, healthcare, social care system. It means that we need to be working in partnerships, especially with our community, in new and agile ways, recognizing that our communities are changing and evolving. It means that we have to think about how we use our data, ensuring that we're really committing to high quality data that can help us to inform how we target, how we evaluate our interventions, and how we improve our interventions as well. Wherever you are in the system, I hope that you'll be looking at how you use research to understand the needs of your communities, and research again to evaluate the impact of your interventions as well. And no change that we should have in the health and care system can be achieved if we're not centering our communities in everything we do. And that's why the neighborhood model is so exciting. That's why the ways in which we bring communities into every level of the NHS and our health and care system to challenge, to check, to support, and encourage will be a key part of what needs to be done. And finally, no change and structural change in the system will be complete if we do not build upon the lessons that we've learned when it comes to naming structural discrimination, dealing with structural racism, and ensuring that we're building a workforce that is truly diverse, equitable, and inclusive, and fit for the future. This brings me then to the end. I hope in the time that we've had that you've seen how these changes which are happening in the NHS are not only new and ambitious, but they're an opportunity for us to think differently. And if we understand how to connect in, we can actually work with the new system to help us to achieve our goals. The 3 shifts that the government wants to achieve are the 3 shifts that we will need also to leverage if we're going to be tackling inequalities. That shift from prevention into the community and digital offers us really new hopes and new ways in which we can accelerate our efforts. Let's partner, let's use them effectively. And finally, it's important that as we do this work, we remain vigilant, we work towards scale, we have the metrics that help us to understand what we're hoping to achieve, and we do this together. Thank you.
Thank you so much,